All right, so I guess I'll start. I just want to apologize. I didn't put a slide in to actually introduce who I am, so I'll just do a quick introduction now. My name is Jason Kwan. I'm a trained family doctor from Nova Scotia, and I'm currently doing an extra year in emergency medicine in Queen's University in Kingston. Um, Places I've worked, I guess I've rotated through Nunavut and Iqaluit. I recently came down from Sioux Lookout. I spent a week there working the emerge. So if you see my name on a couple of documents, that's who I am. Nice to put a face to the name, I guess. And I'm currently in Toronto right now, doing a rotation. I just came off a night shift, so I apologize if I'm a little straggly looking. Um, so to kind of start, the presentation we're doing is the approach to back pain, which is kind of a huge category, but it does quite happen often, and I've been told after the age of 25, it just becomes a daily occurrence sometimes. So we'll just get started. Please feel free to ask questions throughout the presentation. If there are any, just type it in the chat. If I do miss it, please put your hand up, or if someone just let me know that there's a question, and we kind of address it then. I do not mind being interrupted. So the objectives that I put together for this one, this presentation here, is to approach the undifferentiated back pain, to identify emergent and non-emergent causes of back pain, recognizing some initial investigations and managements, and recommending appropriate follow-up, or identifying appropriate follow-up is the key as well. So I always like to start, and I think a lot of presentations start with cases. So using your best imagination, I want you to just kind of picture these patients and their presentation to your clinics. So this is the first patient. They look like a smiling person. So it's an 8-year-old male, comes to your clinic with back pain for 3 weeks. Apparently was playing with friends and slipped and fell 2 weeks ago, had some leg weakness. Describes that the pain kind of worsens with activities. The parent says they wake up from sleep sometimes with this pain, and noted some fevers and cold like without any real cold like symptoms over the past 2 weeks, but does go to school. And so there's also like some fatigue and some decreased appetite with this smiling child. No past medical history, no allergies. And when they were examined, there was a focal back tenderness, and they said, yeah, it kind of hurts where they kind of fell down on it 2 weeks ago, and maybe there's some weakness, but they weren't really fully agreeable to do your exam because of the pain in the back. Okay, so you can put that in your back of your head. Then our second case is this miserable person. Very, very frowny face, as you can tell. It's a 62-year-old female presents with low back pain times 1 week. Works a laborious job, woke up with back pain, just had a really bad sleep and woke up one night and now it's just always there in the lower back. Review of systems in terms of infections or trauma or any specific weaknesses or urinary fecal symptoms didn't really reveal anything, and they kind of describe just if you bend forward, hurts like really bad, and more frowning. They are an active smoker. They don't have any allergies or take any medications, and initial examination was otherwise unremarkable. So we have two very different age groups, two very different patients, and one smiling and one frowning, and you can put that to the back of your head. So, to worry or not to worry about back pain, you've probably already made your decisions about our two cases before. But we want to break our, back pain into major four categories if you look at a lot of the guidelines. So the first one is not spine related. The second one would be radicular neurogenic spinal conditions. So if they have more spine related, I guess, in that case. Serious spinal conditions and non-specific low back pain. And so the decisions that we really need to make with back pain, regardless of the setting in which you practice, is, are we referring are we referring for immediate evaluation now? And so for I guess in Northwestern Ontario, or these patients medevac patients, are we calling the nearest emergency department or the emergency department with the correct resources to evaluate this patient because of our clinical suspicion? Is this more of a SCEDEVAC patient. So not the next day, not immediate. I guess medevac isn't always the next day or the same day, but the next available kind of transport for further evaluation, for more urgent evaluation, but not immediate. Or is this kind of a return instructions the next doctor's day, an email or text? I'm not quite sure how the non-urgent clinic evaluations happen up in Northwest Ontario. Generally, I just got the patch phones for the medevacs and skedevacs. But yeah, so major three categories that we have to think about in terms of management plans. So, like all presentations in medicine, it's always about getting a good history. And pain history, we always can use different types of acronyms. And so the ones that I've used in the past or learned in the past, it's like OPQRST and associated symptoms. So, onset of the pain. And that's a really good indicator of things. Is it all of a sudden that the pain started? Did it happen 5 months ago and slowly getting worse, or is not changed at all? Also the onset of what activities were they doing? Were they lifting something really heavy and then they had a sudden onset amount of pain? Um, what makes it worse and what makes it better? uh how do you describe the pain, right? Is it a throbbing sharp sensation that kind of goes from the back to the front and it's like the worst ever starting all of a sudden? That might be something we need to be worried about. Or is this something that kind of hurt when you're doing something and it kind of just stays there? It's a grumbling pain in the back. Or is it like a sharp pain that runs to the front every so often, and it kind of grabs them, right? So describing your pain is important. Where does the pain go? So like I said, does it come from the back shooting straight forward? Does it wrap around the front? Those are good questions to ask. How bad's the pain? Yeah, how long this is going on for, the time characteristics, has it gotten better, worse, gotten worse, better, and associated symptoms in terms of what you think they are. So getting a really good history about other things. Do they chest hurt? Do they short of breath? Do they have fevers and chills? Are they using any substances? Are they at risk for any infections? Another one that I know was taught at some point in time was called old carts. So there's a nice picture from osmosis about that. Same kind of listing of things that we should ask about when we're doing a good history. So where is the pain? And we alluded to this before. Is it like in the spine or not in the spine? And so we have to remember that not all back pain is mechanical back pain, right? There's a lot of things that, one, are next to the back, around the back, but also in the abdomen, but reflect their pain backwards. Um, and so our list is quite extensive. Um, Renal involvement, like we talked about, or when you palpate the back, or you're concerned about an ascending urinary tract infection or nephrolithiasis. Gastrointestinal, so this nice picture here looks at peptic ulcers, or pancreatitis is a very classic one that also has a lot of back pain. The big one that we get concerned about is vascular issues, right? So if they have a AAA or a dissection of the aorta, gynecological issues. So a number of people who present with cramping or pain or PID that also kind of leads towards a radiation towards the back or kind of like in the lower pelvis. Orthopedic or referred complaints, and also things like pneumonia can present even with back pain. And so, oh, I forgot that I actually filled in these spots here. So like, for example, kidney stones or pyelonephritis or ascending UTIs. In terms of biliary tree pathology. So these patients also present with right upper quadrant pain, but that right upper quadrant pain can sometimes just radiate towards the back. And so what's actually hurting them is a little bit of both. We've talked about some vascular issues, gynecological issues, orthopedic issues, and yes, respiratory like pneumonias and PEs can also present as that back pain. So remember that back pain is not always just the spine, and that's important to think about when you have patients presenting. So, where is the pain? Part two. So, radicular neurogenic spinal causes of this pain. These are about 5 to 10% of presentations. And the classic examples are spinal stenosis or disc herniation, and they cause some form of some neurological changes in their history or physical. And so when we think about them, I highlighted a couple, but there's spinal stenosis where you have like the canal, the spine itself, which sits in the canal, actually is being compressed by something yeah. You can have degenerative disc disease, compression fractures causing pushing against the spinal canal, herniated nucleus pulposus, which is the disc kind of herniating out, right? So the pulposus is the soft inner side of the intervertebral discs, and then there's a fibrous outside shell. But eventually, if there's enough pressure, it can push out this little bit of a central part of the disc, and that can cause specific radicular symptoms or even just onto the canal, which you can cause spinal stenosis. There's other ones to think about in this category here. So discitis or osteomyelitis can cause sometimes radicular pain. Malignancy, if it causes pushing down and compression of things. Okay. Oh, highlighted that as well. And spondylolisthesis. So within this group, we have to be concerned about, and we'll talk about it in a bit, but there are emergencies that can present here, right? So compression of the spinal cord is an emergency and usually can involve surgical intervention for that, depending on the symptoms. Non-specific back pain. So these are about 90% of presentations of back pain. And these are the people that present to the clinic, to emergency departments, and they complain of back pain. And we do a good history, a good physical, and we send them home with the diagnosis of non-specific back pain or MSK back pain. And usually these people have a spontaneous recovery of their back pain in about 4 weeks without doing anything. So, non-specific back pain can be any of the previous diagnoses, really, but hopefully through good physical and history that we kind of rule out all the bad stuff that can be intervened upon. So, quote unquote MSK back pain, because I'm sure everybody's seen this scribble into some emerge note somewhere or in a clinic note. The non-specific back pains or the MSK back pains, if they're truly MSK, we can try to divide these into multiple sections as well. So there's discogenic, in this case, disc diseases that we talked about, right? Herniation or degenerative issues causing a specific pattern of pain. Canal stenosis as well, mild, moderate, and severe, and these are generally without quite pronounced neurological symptoms or cauda equina is the name that I'll put it, or in some textbooks you might list it as epidural compression syndromes. We have facet joint pain, right? So any joint in the body is susceptible to osteoarthritis, degenerative wear and tear. I had a finger from climbing that's now the joint is double the size of every other finger, and it can happen at any age as well. So if it's that joint pain can happen. And then nerve compression and sciatica. So these are also kind of sciatica has been thrown around a lot, but yeah. So if you have an injury or a change in the anatomical structures within the back that causes compression of the nerves, that could reproduce specific pains. And then I put down on the bottom, this is not really always listed, but muscular. So patients who present with paraspinal back pain or strains and sprains, and they have very clear trigger points, they can also present with what we call MSK back pain. So the big things to think about are always the red flags, the emergencies. These are the ones that require urgent evaluation, or at least a discussion urgently if there's concern. And listed within it are the conditions that, without specific intervention, can cause increased or significant morbidity or mortality. And this is the less than 1% of the presentations of back pains. It very much depends on the center that you work at as well. So if you work in a oncologic hospital with an emergency room like Sunnybrook, you're probably going to see a lot more. Versus if you work in a community setting, you might see more of the MSK back pains, and this 1% could be reflective. So it really depends on the population in which you work with. And so this is straight from a tool called the Core Back tool. And this is something that I think greatly it is recommended by the Canadian College of Family Physicians or the College of Family Physicians of Canada, and really incorporates all the important things from a red flag perspective that requires more urgent, if not immediate, evaluation. And they say using the acronym of NIFTY. This is also a tool that you can print off and just have in your clinic ready to use. And it has check marks and boxes that you can kind of tick through to try to not forget about the really important things as well. So if there's neurological changes, deficits, this is probably someone that warrants more urgent or immediate evaluation. Um, because if they present with like epidural compression syndrome or cauda equina syndrome, these are patients that require an MRI and they require surgery, and so they need a neurosurgeon at the center in which you're referring to, and they also need an MRI at the center that you're referring to, right? So these patients, if you have a very good story of someone that comes in, and as you can see down here, oh, you can see my mouse. I guess I could change this to pointer options. Oh, yes, here we go. So if you present with cauda equina syndrome, which is usually urinary retention, there's some weakness bilaterally, sometimes there's fecal incontinence, or they have loss of sensation in their groin region, specifically this perineal region. These are patients that if you talk to the physician calls the Sioux Lookout, as the emerge doc working in Sioux Lookout, which is like you're really concerned about cauda equina, this patient, regardless of whether or not they come here, probably needs to get an MRI and eventually needs neurosurgical evaluation. So this is a patient that probably should not even be medevaced to Sioux Lookout. It needs to be medevaced to somewhere where there is an MRI for evaluation. Because you want to look at specifically the spinal cord and how the level of compression or what is actually causing a compression of the spinal cord. If the patient presents with fevers or they're a high risk for potentially developing an infection, so classically there is IV drug use, which is a risk factor, or they're significantly immunosuppressed. This is a patient that is at a risk of developing things like discitis, which is the inflammation of the discs themselves from an infection, or developing things like spinal epidural abscesses, which cause compression, and they can also then cause neurological issues. Um, and so these patients also require usually an MRI at some point, but a little bit more trickier because there's 1,012 things that can cause fevers. And so, in the context of back pain, we have to be suspicious, but might just need more workup before pulling the trigger on an MRI. Fractures, this is in their red flags because it will require more management. And it's important to ask about trauma, but not just the classical car versus person trauma or fall, but also thinking about interpersonal violence is something to think about for someone with weird atypical trauma-like story and new fractures or bruising, just to look for other causes that could result in broken bones. Then these patients tend to, especially if they're a bit older, need to be assessed and screened for osteoporosis or other potential pathological reasons for having a fracture, if it's not really, or if it's atraumatic. And so they will need imaging, generally speaking, if there's a high suspicion. And it's listed here as a red flag, but I don't, depending on the story, it's not necessarily a medevac, and can be even, like, I don't know if it's really viscinovac. And so this would be someone that you could discuss with the physician on call about, or fitting them in for more urgent evaluation. Depends on the story, really. Tumor. This is, fevers, unexplained fevers, weight loss, night pain, severe fatigue. These are kind of the history that you can take to be suspicious about a tumor resulting in malignancy-related back pain. The most important question that we need to ask if you're suspecting an oncologic emergency or oncologic cause of back pain is history of cancer. And then inflammation is another one. So if they have morning stiffness, they're a younger individual, the pain is not improving generally, and it only gets better when they start to get moving after about 30, 45 minutes in the morning, and they get really stiff when they stay still. These are people that require probably urgent evaluation and blood work and imaging. Um, Sorry. And I just want to add two other parts to the worrying story of red flags. And these are, it's good to kind of have these red flags of the nifty criteria in your head, but also to think about how bad, like if their pain is really bad, sudden and unrelenting pain probably needs urgent evaluation, or they have a really bad cause of it. Severe intractable pain. You give them Tylenol, it doesn't get better, and it's like really, really bad. These are people that you probably need more urgent evaluation. Um, and so it's not really listed there, but from a clinical judgment perspective, is this pain really, really bad, sudden onset, unrelenting, can't do anything about it? It probably needs to be evaluated more urgently to make sure we don't miss anything bad. In general, if someone presents to you with more than 6 weeks of pain, this is probably people that also need to be examined and probably needs basic imaging as well. So back to the red flags. Oh, I went into more detail here. And so tumor malignancies, usually there's no, the primary tumors, so tumors or malignancies originating in the back are not very common, but they're possible and they can be possible in children. But generally, there's a list of cancers that, in med school you had to memorize, and they are realistic because they present in family practice all the time of potential metastatic disease and big considerations. So prostate, breast, colon, lung, thyroid cancers, uterine and malignancies can all move towards the spine and cause back pain. Um, Inflammation, so these are morning stiffness in younger age, like we described above, and fracture because it's on that list. These are patients that require probably more urgent evaluation, right? And so is this a skedevac? Is this an emergency? They moved over to the medevacs, or this more kind of an urgent evaluation and assessment. So these are some of the bad ones. Like I talked about before, unrelenting pain, sudden onset, severe pain. We think about ischemia or dissecting aortas, or an aortic aneurysm that's not doing so hot. Infections for risk of abscesses or discitises, and compression or epidural compression syndromes or cauda equina can cause these symptoms specifically with saddle anesthesia or urinary retention, which is the big one to think about, and fecal incontinence. And these are immediate evaluations. And so urinary retention, I just want to point out here, it says post-void residual. Just also be mindful that sometimes people have such bad retention they could get overflow incontinence of the urine. So it's always good to say, hey, if this patient has urine incontinence and they feel full, or you want to do the post-void residual, so it's good to check to see how much that they actually retaining, because anything, depending on the resource that you look at, between 100 and 200 cc's in their bladder is retention, and with back pain and leg weakness, these are patients that probably need more urgent evaluation. Okay. So, just to kind of round it out, approach to physical examination for these patients. Always look at the vitals. Vitals are vital, and they tell us a lot of information. How do they look? Look well, look bad, look they're normal, look worse than normal, look happy, look sad. These are kind of things that kind of put things together in your head. And especially when you're on the phone talking to someone else, like it helps kind of build that picture and that mental image that you were seeing to that patient on the other side of the phone. A precordial and respiratory exam. It's always good to listen hard. So if you hear a large amount of crackles and they're coughing and they have fevers and they have back pain, then that leads you towards making sure that this is a pneumonia. But sometimes pneumonia presents pretty kind of quietly, right, with just that back pain and fevers and chills. And it's good to kind of get a good listen. Abdominal exam is always good to feel like, hey, like they complain about back pain, but actually they also have suprapubic pain, and you ask about their urinary history. They also have a bit of burning and frequency and hematuria. Or you feel a giant throbbing mass in the center of their belly, and now you're concerned about potential aneurysm that's causing their attributed back pain. A neurological examination, and we can kind of go through that a little bit in just 1 second. Oh, and this is the second now. So how do we assess for weakness? And I guess I'll kind of give my general approach for doing a neurological examination. You can take it or leave it. Uh, but the first thing is kind of in that appearance, right? So if they're in their clinic, did they walk into your clinic? Are they in a wheelchair? They're using a cane? Did they sit down in the waiting room? Are they able to get from the waiting room to your exam office? And then when they do that, do they need both hands to really push hard to get up? Are they dragging one leg? Do they have a foot drop? Is one side kind of not moving? Are they in like a hemiplegic state? These are all kind of like good things. You can tell a lot from someone's walking. And the other thing to think about is this their normal or baseline, right? So if they had a previous stroke and they have left-sided weakness and now they're walking with left-sided weakness, is that normal? Is that not normal? And then I kind of alluded to it during the observation stage. Take a look at them from sitting to standing. How much effort do they have to get from sitting to standing? Or are their legs weak because they got to get up to standing? And then I also see what they do when they're standing to sit, right? So when they have to lower themselves down again with their arms because their legs are weak, do they just immediately collapse into the chair? Do you have to physically move their legs, like pull their pants up to kind of get in position to sit in the chair or get comfortable in the chair? Looking at their arms, right? So there are testings for all the arm strengths, leg strengths. And the big one to think about is you can get them onto a table. You can do a straight leg raise, which tells you a lot of information about function, strength, and even potential etiology, depending on if you can recreate pain by doing a straight leg raise. If you can't get them to an exam table, a good thing to do or a good surrogate is also to check, like, are they able to extend their knee in a flexed position while they're sitting? Perineal sensation. I don't honestly do this all the time, but it's something to think about. If I have someone that I'm suspicious for chronic climate, then I will do a saddle sensation, so perineal sensation, as well as potentially plus or minus a rectal tone. And that kind of leads you towards whether or not this is a surgical emergency requiring immediate imaging or not. Cranial nerve exam. If it's specifically focally for just back pain, this is probably someone that I probably won't do a cranial nerve examination for. But in my head, when I think neuro examination, or someone says to me that they did a neuro examination, it includes a cranial nerve exam. So, um, yeah. And then I talked about it baseline. In the core back tool, and and I'll show you the form later, but it also includes a list of important key hit things on the neurological examination that you want to assess for back pain. So gait, standing, sitting, kneeling, lying down. And the greens and bold are the ones they think that you should be doing at all times. So reflexes is an important one that I actually did not include into my neuro exam section on the side here. But yes, reflexes would also be important if you suspect there's potential cord involvement. So back to the MSK back pains. So there's four bolded categories here. And interesting enough, through the core back tool, through the research, and I guess Hamilton, I think it was Hamilton Hall who created it. But they have four categories of back pain that actually present with specific patterns. And so putting those in mind, discogenic, canal stenosis, facet joint pain, and nerve compression sciatica, you can use history to help narrow down a different pattern. So there's 4 patterns, right? Pattern 1, 2, 3, and 4. And using 3 basic questions, there's a high probability that you can sort out this MSK back pain to one of these patterns. Again, before you go down this list, think about other things that can causing back pain. So make sure you're really in that non-specific back pain category and you're thinking, hey, is this mechanical back pain? So is it back or butt dominant or is it leg dominant? So where is their pain worse? If it's down their leg, that leads you down one particular pathway in terms of causes. And if it's back or buttock dominant, it can lead you down a different way. Is the pain constant or intermittent? And then what makes the pain worse? And also what makes the pain better? And those are the 3 questions that can lead you down to different patterns. Remember to rule out your red flags and remember to think about other causes of mechanical back pain. And then there's other questions in this tool, but the other tool questions, it kind of, again, goes back to like making sure this is not cauda equina, making sure you've asked the questions, to not have to be suspicious about a surgical emergency. And then you've also asked some questions about whether or not the patient is at risk for having a rheumatological cause of their back pain that would benefit from medical therapy. So these 2, again, immediate, that one's immediate for intervention. So if you suspect cauda equina, and if they have a risk of arthritis or arthritic leg pain, these are patients that would benefit from more urgent evaluation. Not necessarily the next flight out, but eventually blood work and imaging. So moving to section C of this core back tool, the different patterns and what the cause of those back pains are. So pattern 1 is your disc pain. So these are the patients that, again, have back or buttock dominated pain, and the pain is usually always there, and it gets worse when they lean forward and gets better when they lean back. That gives it a high degree of suspicion that this is probably a disc-related pain, and this particular tool walks through, and I think walks through exercises, which is number 1. Treatment for all these pains is exercises, essentially. And my preference is actually the SASC pattern 1. So in the family practice, I would print this off for patients, and most patients fall either pattern 1 or for pattern 2, and you just hand them the pattern, and you can look at the exercises that they offer or list there. There's pictures, it tells you how many reps, how many times a day, and really these patients would benefit from, again, our physiotherapy colleagues to help individualize these plans and these exercises to really get people moving and get them out of this pain. It tells you also follow-up. So anywhere between 2 to 4 weeks is fair. And also talking about if there's like self-management goals in terms of what we want to do in terms of pain management. Pattern 2 is your facet joint. So that was the one I'm talking about, that everybody eventually gets osteoarthritis in some places, or they have overuse injuries that can cause back pain. And these are the ones that have intermittent back pain that both unfortunately worsens whether or not they go through flexion or through extension. Generally gets better with flexion, but can also be quite painful initially. Pattern 3s and 4s, these are your leg dominated pains. So leg causing pain, right? If it's a back pain cause or mechanical issue, think nerve involvement. So neurogenic claudication is one of them, or spinal stenosis, or compressed nerve, which includes sciatica. And they have also resources here in pattern 3 and pattern 4. Just be mindful that pattern 3 requires close follow-up if there's a compressed nerve of some sort, because they could get worse, or they don't get better. They would benefit from potentially imaging. Spinal stenosis, depending on the level of functional impact, you want either closer or further out follow-up. In general, most people who in this category eventually go out for, let's say, advanced imaging like MRI, or even just x-rays that demonstrate kind of multi-level degenerative disc disease. Again, without the issues of cauda equina in all 4 of these categories, or they don't need emergent surgical intervention, and most of the time they don't even require surgery at all. But this is something that if the pain is not going away and it has functional impact, this is probably getting into the categories of good follow-up and eventually even outpatient advanced imaging and then considerations for surgery if it's not improving pain. And if they don't fit any of these four categories of mechanical back pain, then you go back to like maybe this is not mechanical pain. And then going back to where I would argue is the first step in someone with back pain is to consider other causes. And so here they list out all the things that we kind of talked about at the beginning. But I would argue we should not go through these patterns and then have ourselves pigeonholed that this is mechanical back pain, but rather think, could this be anything else but mechanical back pain? And then see if the pattern fits to one of these etiologies. That would be my recommendation. Ooh, follow-up, I highlighted there. So going back to the non-mechanical back pain, I started with it, went through all the mechanical back pain, and now I want to go back to it because I think it's a list of things to think about, and there's a lot of things that can cause back pain. So, do we remember the list from before? And I know there's a lot of people on the call, but I understand that it's not fun to list out a bunch of things, but if anyone wants to, you're welcome to. So associated symptoms on history and comprehensive physical exam. So like I said, like listen to the chest, feel the belly, watch them move. These are things to look at. Do they have primarily gynecological causes? And this is a cyclical pain that, the times that you can kind of pick up maybe these occults, not really occult because they're not presenting with quite bad pain, but endometriosis in the patients, whose pain is worsened with their menstrual periods, and now it's kind of like migrating and changing. Yeah. So there's a list there. Renal issues. Is it a belly issue? Is it a pipe issue? Is it a structural issue in the pelvis? Is it a orthopedic issue? Or could it just be a lung issue? And again, there's a lot of things that can cause back pain, and I would argue that we should think about this list before we scope in onto just, mechanical back pain. Because once you put a diagnosis of mechanical back pain, then it's harder to come out of that diagnosis, and their follow-up will be 2 weeks later, and things could have changed or gone worse. We need to think about the immediate evaluations. Is a medevac or delayed urgent evaluation like a skedevac or next doctor's day? Just be cognizant of a lot of pathologies in back pain do require further imaging and workup. This is an example of the core back tool, right? So I used kind of excerpts, screenshots essentially, of this document in multiple parts of my presentation. And it can be printed off double-sided. And if you're really in that camp that this could be mechanical back pain, then working through this worksheet, and if it fits a specific pattern and they don't have any red flags or emergencies, there are recommendations for initial exercises that you can do at home pending physiotherapy or further evaluation, and also referrals if they require. And I think one of them is rehabilitation. A lot of them are rehabilitation. And there's even a list for surgical referral as well. So like I said, these are patients that generally fail conservative treatment. Their pain is so bad that they cause them to not functionally have such bad functional impact, that these patients might benefit from a surgical evaluation or consideration for surgery. So let's go back to the cases. Oh, there's a chat message here. CV and tenderness versus muscular. Is it just the history and associated symptoms that would help distinguish between the two? Yeah, so I mean, definitely. The question that was in the chat was differentiating between CBA tenderness and MSK back pain. The story is a big piece, so history. And associated symptoms, right? You don't necessarily get CBA tenderness without the classic urinary tract infection symptoms. In terms of MSK pain, generally, if it's in that same area, your patients, like the story, the history will tell you. And if you're really concerned, you can get a urinary analysis, right, and look for a source of potential infection. But yeah, CV tenderness in the context of pyelo, generally patients will have fevers, right? MSK back pain won't have fevers. And if they do have fevers, either it's a coincidence or they don't have just MSK back pain, and we have to look a bit harder. Yeah. I don't know if that answered your question. Sorry, I got to your question a bit late. So we'll just keep on trekking here. So cases revisited. Oh, I was gonna actually like do this in bits and pieces because every part of the story I put in quite deliberately, and I thought I had made it like disappear. And I was gonna say, how does it change your management? So if I cover up the first thing, so 8-year-old male comes to your clinic with back pain times 3 weeks. Just that kind of statements alone kind of makes me concerned. One, kids, they have back pain as well. That's not an uncommon thing. The question is when the kid is like, I actually want to go see someone about this back pain. That to me is actually like a pseudo red flag to think about. And it's been going on for 3 weeks. Why has it been on for 3 weeks? How's it changed, right? And then when you kind of clarify the story, it's like, oh yeah, it's been going on for 3 weeks, and but then they slipped 2 weeks ago. So, when something doesn't add up on history, it should really clarify, especially in these kind of positions. So, does Thunder Bay or Winnipeg do neurosurgeries? I believe Winnipeg definitely does neurosurgeries, but ultimately, I think you need to go to a center which that has MRIs. So if you're really suspicious about CAUDA or a canal pathologies, neurosurgeon probably will not see this patient unless they have an MRI done. And and Thunder Bay does have neurosurgical capabilities. So thanks you, Melissa. Yeah, so clarifying the story. So, did their back pain start after their fall or did it start before their fall? And so I put these two there because, if you clarify on the story, the kid is like, yeah, actually, no, it's been hurting before the fall, but I fell and it still hurt. And then leg weakness, and you ask, what do you mean by leg weakness? Well, I can't jump as well as I could have, or I don't feel like I can jump as high as I can. A pain that worsens with activities, and then, so let's see if I highlighted. I'm pretty sure I did. There you go. So I bolded a lot of things that I would think of in this story that makes me concerned. Right. So a child that comes to ask, or this to ask to come to your clinic because of back pain, as opposed to just complaining of back pain and then going doing the things and complaining of back pain to their parents, and they say ow here and there, and so now the parent's concerned, but the kid is not. But if the kid says they like are have their pain and they're concerned, this makes me suspicious. Fell 2 weeks ago as opposed to 3 weeks of pain. They had new leg weakness. They can clarify by story. What do they mean by leg weakness? Because that's important to know. It wakes them up from sleep. So night pain is a big bad red flag that always should be suspicious about. Fevers without any kind of infectious symptoms for the past 2 weeks that are unexplained, fatigue, decreased appetite. And I didn't put in here about weight loss. So asking about weight loss, but they didn't complain about weight loss in this situation. And on physical exam, focal back tenderness, sure. So midline pain, but objective 4 or 5 weakness bilateral in their legs, and they look more pale. This is someone that I'm very concerned about. And if you haven't, if everything's not screaming out yet, then like we're concerned about malignancy for this kid, right? And so there's some primary oncological malignancies or cancers in 8-year-olds, but with pallor, this patient probably needs to get some at least basic blood work and imaging, like an X-ray, and probably needs more urgent evaluation, and likely a referral to even peds at the end of the day, if not to a more specialty service. So I would leave this up to the discussion of the physician in the clinic and how fast and quick that we'd be able to get investigations done. But this is someone that if you wanted to send out to Sioux Lookout for immediate or urgent evaluation, I wouldn't say no. Maybe not a medevac in this case, unless there's other kind of points to the story that make us think that there's something acutely or surgically emergency, but definitely an immediate evaluation. And if I got this phone call, I would be like, yeah, like, come down. And so, cases revisited. So this is our 62-year-old with low back pain. The frowning face. And so things to think about in this story that make us concerned, active smoker, so puts them at risk for osteoporosis, age, in this case, not over 65, 62. Female, so postmenopausal, would put them at risk for osteoporosis as well, weakening of the bones. Um, and the story kind of fits in this case of mechanical back pain. But we also have to think about there could be a compression fracture or vertebral fracture in the context of osteoporosis. So if your exam revealed midline tenderness, this patient probably could deserve to have an X-ray to look for a potential fracture, compression fracture, or vertebral fracture, or atraumatic, which means that they would probably require further workup for assessment of osteoporosis, and also like screening blood work as well. And so, if we were to think about this particular story and lean more towards MSK back pain, here there are a flow chart again from the core back tool that we can kind of follow to see where we're at in terms of things. So, low back pain is persistent, so back dominant. It's constant. They do not have any red flag symptoms or physical exam findings that would make us lead to more immediate or urgent evaluation. They actually have more flexion-associated back pain, and as such, this is kind of fitting of that pattern one, which if we go down to the pattern one, this is more of a disc-related pain, which fits a lot with their laborious job and their symptomology. And it provides doing extension exercises to try to get to help with the pain alleviation. So this is the cat-cow. I'm not familiar with my yoga terminology, but I think that's one of the positions. And yeah, so appropriate follow-up as well within 2 to 4 weeks. This is someone that probably does not need urgent or immediate evaluation. But if their pain doesn't resolve or there's midline pain, these are things that we should consider getting imaging and further workup for. So I put this at NetDocs today or email. This is consider talking to a physician about Tylenol, Advil, initial exercises for MSK back pain. So if you type in SASK pattern 1 into Google, they have like a really nice worksheet and images of these exercises that you can do. And then HealthLink BC also has a lot of resources as well for these MSK back pains. So in terms of objectives, covered a few of the approach to undifferentiated back pains, kind of recognizing some emergent, non-emergent causes, initial investigations and managements, and also recommending appropriate follow-up. Yeah, so that is the presentation. Let's take a quick peek here at some of the questions that are going around. Okay. So, can you mention cervical stenosis signs missed frequently? Yeah, this pain, this presentation mainly focuses on back pain, not necessarily cervical pain, but yeah, so cervical pain, if they have radiculopathy, down either one side or bilateral in their arms, so paresthesias, numbness, weakness in their arms. These patients also sometimes present with pain in their neck, and you can also do specific maneuvers at bedside. So there's a couple of physical exam findings. You do like Sperling's tests where you kind of strain the neck to see if you can recreate the compression of a nerve onto left or right side. These are symptoms of potential cervical stenosis that can occur. Again, also checking weakness, true weakness in their arms and their hands, and definitely their hands, to look for potential nerve root compression and on which side. These are patients that you probably need to get more advanced imaging in order to diagnose if you have cervical stenosis, but also be mindful that sometimes identifying cervical stenosis doesn't necessarily change management. We want to look for red flag symptoms specifically to get more urgent imaging. These are they present with more extremity weakness, either bilaterally or one-sided. And if you actually, I don't have the image here, but if you look at the spinal, if you look up cervical spine and the spinal cord, and you look at kind of where the pattern of compression can occur, these are patients that they eventually can slowly lose function over time, and so in a specific pattern. So you can refer for imaging further for those. Would juvenile arthritis present similarly? So juvenile arthritis presents uh, yeah, but juvenile arthritis generally presents with more kind of extremity joints, so knees, are the big ones. But we want to like think about any in this case for specifically if they present only with back pain and no other associated joint related issues, so ankylosing spondylitis. And you can do that from blood tests and also X-rays to look for rheumatological issues primarily with the back. But if they have other joint involvements and swelling, such as like one or two knees or their wrists, again, they can also present with fevers. These are patients that you would have to assess for juvenile arthritis and probably get a pediatric rheumatologist on board to ensure that you order the correct set of blood work instead of poking multiple times. Um, yeah. EMG testing, neurological assessment. Yeah, so there's some, depending on who you talk to, there are roles for EMG testing if there is weakness that's identified and you ruled out all the potentially red flag or urgent or emergent causes of their back pain. So EMG testing is important if you find any isolated weaknesses and you're looking for there's a particular nerve compression that can be explained. For classic sciatica, no, I wouldn't necessarily advise to get EMG testing as first line, and I don't do EMG testing for most of people first line because from where my understanding it's difficult to get. And so imaging is probably more first line than getting EMG testing. Don't know if that helps.
Okay. Any other questions? Right. Oh, I see another pop up here as we're talking. Oh, thanks. Okay. Any other final questions? Comments? All right. Thank you so much for your time this morning, Dr. Kwan. And thank you everybody for giving us an hour of your Thursday morning. Have a great week and we will see you all next week.
Thank you.